Welcome to The Explainer. Today, we are getting your knowledge on cirrhosis and portal hypertension absolutely exam ready. If you're looking to crush your upcoming exams or shine on your clinical rotations, well, you're in the exact right place. We're going to break down the pathophysiology, the clinical signs, and those critical emergency management protocols you absolutely need to know. And we're going to use some fantastic visual frameworks to lock it all into your long-term memory. Let's get to it.
Okay, here's our roadmap for today. We'll hit the signs of liver cirrhosis, portal hypertension core concepts, managing variceal bleeding, ascites and SOG analysis, grading hepatic encephalopathy, and finally, PBC versus PSC.
Starting off with Section 1, Signs of Liver Cirrhosis, recognizing the physical stigmata.
So we're starting strong with the classic physical exam findings that immediately point to a failing liver. A declining liver literally writes its story right on the patient's body. Seeing these physical stigmata is an immediate clinical red flag for underlying chronic liver disease and decompensation. For instance, when a damaged liver can't clear estrogens from the blood anymore, what happens? You see spider nevae, palmar erythema, and in men, gynecomastia and a loss of body hair. Plus, a failing liver means a big drop in synthetic function, leading to low platelets and coagulopathy, which shows up as unexplained bruising. And hey, if you see a jaundiced patient with a flapping tremor, also known as astrixis, you are looking straight at hepatic encephalopathy. Lock these into your brain, guys, because they are classic exam question stems.
Moving right along to Section 2. Portal hypertension core concepts, the hemodynamic traffic jam.
I want you to think of portal hypertension as a massive hemodynamic traffic jam. The normal hepatic venous pressure gradient, which is just the difference between the wedged and free hepatic venous pressures, is typically a very low 5 to 6 millimeters of mercury. But notice that a gradient exceeding 10 millimeters of mercury is the exact threshold for clinically significant portal hypertension. Why does this exact number matter so much? Because once you cross that 10 threshold, and especially when you push past 12, the risk of life-threatening variceal bleeding just skyrockets. The cirrhotic liver becomes the stiff, fibrotic roadblock, basically forcing all that splanchnic blood backward.
Now take a look at this CT scan. It's a perfect visual summary of the pathophysiology. See that shrunken, nodular, cirrhotic liver right there? Because blood just cannot flow through it easily, the high pressure backs up into the portal system. That causes that massive, swollen spleen you see, splenomegaly, and it actually forces fluid to literally leak out into the peritoneal cavity, creating ascites. It's incredible how this single image captures the exact downstream effects of that portal traffic jam. Which brings us to Section 3. Managing variceal bleeding, a life-threatening emergency.
Next up is the absolute highest stakes complication you'll be tested on. Because of that intense vascular resistance we just talked about, the body desperately tries to find detour routes. It shunts portal blood into the systemic circulation. And the terrifying result is what you're seeing right here, engorged esophageal varices viewed during an endoscopy. As collateral vessel formation progresses, more than half of the portal blood flow can end up being shunted directly to the systemic circulation through these alternative pathways. They are incredibly fragile, dilated veins sitting right near the surface of the esophagus. They are literally a ticking time bomb for severe hemorrhage.
If they bleed, you have to follow this exact step-based protocol. Memorizing this specific order saves lives, I promise you. Step 1. Start with intravenous fluids to cautiously replace intravascular volume. Step 2. Immediately give a vasopressor, like terlipressin. This directly reduces that high portal pressure we discussed and slows down the acute bleeding. Step 3. Administer prophylactic antibiotics, specifically an IV cephalosporin. This significantly cuts down the incidence of spontaneous bacterial peritonitis and actually improves overall survival in cirrhotic patients with GI bleeds. And finally, Step 4, rapidly bridge the patient to emergency endoscopy to confirm the variceal bleed and perform a mechanical variceal band ligation to stop it in its tracks.
All right, Section 4, ascites and SAG analysis, decoding peritoneal fluid.
When a patient develops that fluid accumulation in the abdomen, analyzing the fluid is hands down your best diagnostic tool. The SAAG, which stands for serum ascites albumin gradient, is a simple mathematical subtraction. It's just your serum albumin minus your acidic fluid albumin. Now memorize this specific split. A SAG greater than or equal to 1.1 grams per deciliter definitively points to portal hypertension as the driver. This includes causes like cirrhosis, right heart failure, or Budd-Chiari syndrome. It basically tells you the fluid is being pushed out primarily by high hydrostatic pressure. But if the SAG is lower, so less than 1.1, the high pressure isn't the main problem.
A low score means you need to hunt for entirely different mechanisms. Think nephrotic syndrome, tuberculosis, or perineal carcinomatosis, where the fluid is leaking due to inflammation or low oncotic pressure. Remember, 1.1 is your magic dividing line.
Moving to Section 5, Grading Hepatic Encephalopathy, the brain on ammonia.
So we're shifting gears from the abdomen up to the brain. When the liver fails and blood is shunted around it, gut-derived neurotoxins, mainly nitrogenous substances like ammonia, completely bypass the liver's filtration and enter the systemic circulation, eventually poisoning the brain. This table is a perfect mental flashcard showing how this progressive buildup systematically shuts down cognition. Just look at how it scales. Grade 1 starts relatively mild, right? You'll see poor concentration, slurred speech, and an inverted sleep-wake cycle. Grade 2 is where you see lethargy and that classic physical sign we mentioned earlier, the flapping tremor or asterixis. By grade 3, you're looking at marked delirium and gross disorientation, though the patient still responds to pain. And grade 4 is the most severe, a complete coma, entirely unresponsive to voice.
To actually treat this, you have to understand the triggers and the underlying mechanism. Common triggers include GI bleeding, constipation, infection, or dehydration, which is often caused by the very diuretics we use to treat ascites. Because gut bacteria produce these neurotoxins, the mechanism to treatment logic here is beautifully elegant. Our main goal is to suppress neurotoxin production directly in the bowel. First, we use lactulose. It's an osmotic laxative that actively lowers the colonic pH. This acidic environment traps ammonia by converting it into non-absorbable ammonium, which is then just excreted in the stool. Second, we use rifaximin. This is a non-absorbed antibiotic that stays right in the gut to wipe out the offending ammonia-producing bacteria altogether. So you trap the toxin and kill the bacteria making it. It's highly effective and super testable.
And our final section, Section 6, PBC versus PSC, the biliary differential.
Let's break down a classic board exam differential that trips up a lot of people. You really want to put the stark contrast between these two conditions side by side in your mind. PBC is classically seen in older females with a massive 9-to-1 female dominance, usually around age 50 to 55. It's strongly associated with other autoimmune conditions like Sjogren's syndrome and a positive antimitochondrial antibody, or AMA. Crucially, on an MRCP image, the large ducts will look completely normal. PSC, on the flip side, presents predominantly in younger males, aged 20 to 40. Its major disease association is ulcerative colitis, which is a huge red flag in clinical vignettes. PSC patients are often panca positive, and if you image their ducts, you'll see a classic beating and stenosis pattern of the biliary system. Microscopically, we see the actual reason for that ductal stricturing and beating in PSC. Look at this highly testable onion skin fibrotic scarring. Notice how the thick bands of fibrosis are wrapping entirely around the bile duct, concentric layer by concentric layer, completely choking it off. This inflammatory and fibrotic process ultimately obliterates the biliary tree, leading right back to biliary cirrhosis and the portal hypertension we started this whole explainer with. Talk about coming full circle. I'm going to leave you with this clinical vignette to test your new knowledge. If a 45-year-old male with a history of bloody diarrhea presents with jaundice, fatigue, and an elevated alkaline phosphatase, which of the two biliary diseases is the most likely culprit, and what antibody would you test for next? Can you connect the dots between his symptoms and the underlying pathophysiology? Think about the demographics, the bloody diarrhea hinting at inflammatory bowel disease, and how that directs your diagnosis and your next diagnostic test. Review this explainer as often as you need. It is your absolute blueprint for getting exam ready on this topic. Thanks so much for joining me today, and never stop questioning.